My name is Dr. Michael Guido. I'm the Director of Stroke Neurology over at Stony Brook University Hospital. And I'm here today just to introduce the concept of mobile stroke units. So to first understand why these are important, we have to understand a little bit about stroke. And I'm sure you already know this, but repetition never hurts. Just some basic epidemiology about strokes. Every year, about 800,000 or so patients have a stroke. About 610,000 are first or new strokes, and about 185,000 are recurrent strokes. The mortality is not super high, but more importantly, the most important effect of stroke is disability. It reduces mobility in more than half of stroke survivors, particularly in those over age 65. But strokes are not that uncommon even in people under age 65, and is a significant cost to the nation. Estimated $34 billion annually, which is not just the cost of healthcare services and custodial care, but also lost productivity and income for those who are under age 65. In Suffolk County, heart disease and stroke are the top leading causes of death. The adjusted mortality rate for stroke is 25 per 100,000. But again, that significantly underestimates the burden of disease because the burden of stroke is really more morbidity than it is mortality. When a patient is having a stroke, the most important thing is to recognize and treat them promptly. Neurons have very little capacity to have very little reserve of oxygen and glucose. So when you isolate a neuron from its blood supply, the cells die within 4 minutes in vitro. In life, neurons can survive longer, but that's because of help from astrocytes and partial flow from other vessels we call collateral flow. But none of that lasts very long. The quicker you get to the patient, the quicker you treat the patient, the better they will do. Once the neurons are dead, they're gone forever. The human brain at this point has no capacity to regrow neurons. So we have to stop the damage before it starts. We estimate about 2 million nerve cells die every minute after a stroke. So as you can imagine, time is precious. For every 15 minutes faster that you treat a patient, the patients are more likely to go home, they're less likely to die, they're less likely to have hemorrhages, and they're more independent when they are discharged. The current guidelines recommend giving intravenous TPA, which is really the only FDA-approved medical treatment for stroke, within 4.5 hours. But the number needed to treat, the number of patients you have to give the medicine to in order to help, doubles with every passing 90-minute epoch. So you only need to treat 5 people to help 1 in the first 90 minutes, it's 9 in the second 90 minutes, and it's up to 14 in the third 90 minutes. Beyond that point, the number needed to treat exceeds the number needed to harm, and so the treatment becomes not available. And that data is strictly for the common medical treatment of intravenous TPA. Of course, the biggest push now is to treat intraarterially, to bring patients to a comprehensive stroke center where they can receive intraarterial treatment and direct clot extraction, very similar to what's being done in cardiology for acute heart attacks. We have here just the concept of act fast, simple ways to recognize that a patient is having a stroke, weakness in their face, weakness in their arms, and slurred speech, with the T emphasizing the importance of timely management. Much research has shown that specialty stroke care saves lives. So we have here 3 studies from 2003 to 2004 from Drs. Kaplan, Lee, and Kazmersky, all showing that being treated at a dedicated stroke center improves your outcomes. A few words about our hospital. We are Suffolk County's only level 1 trauma center. We are the county's first comprehensive stroke center. We have advanced imaging capabilities. We can treat large and complex ischemic stroke, intracerebral and subarachnoid hemorrhages. Treatment is, of course, available 24 hours a day, 7 days a week. And we can optimize patient outcomes through quality improvement and performance tracking, et cetera. So the general concept of this whole meeting is, I'm sure you've seen the slide already today, the concept of hub and spoke. The hub is where the physicians are sitting, and the spoke is where the patient's receiving services. The concept of the mobile stroke unit is to take this and make the spoke the actual patient's house. So our quality metrics is that when a patient arrives at your hospital, TPA must be given within 60 minutes of arrival. But that's the ultimate goal, but now the preferred goal is 45 minutes. And honestly, when the Joint Commission came for our comprehensive stroke review, they're really looking to push that to 30 minutes. very difficult to get a patient treated that quickly when you've got to go to their house, get them, bring them to the hospital, then start IVs, then scan them, et cetera. The mobile stroke unit is a concept where we can take an ambulance, which is fitted with a CAT scan machine, staffed by medics, radiology technicians, and nurses, that can go to the patient at the time of the first call, evaluate the patient there, video link that to a neurologist sitting at the hub institution. We can assess them for hemorrhage. We can administer TPA right in the field. Not going to be any way to get it much faster if you're giving it to them right in their own backyard. And then transfer the patient where it's appropriate. And you'll hear in a few minutes, the more modern machines even have the ability to do CAT scan angiograms, so that we'll be able to detect those who have large vessel occlusions and who would need transfer to a comprehensive center for emergent thrombectomy. And all of this is in the interest in getting the patients quicker, getting them treated quicker, and getting this way we can minimize the damage and loss of neurons. Now, video, of course, is helpful for having a more accurate assessment. They could call us by telephone, but it's much better if we can see the patient. Obviously, we're not going to be able to examine the patient, but that's kind of the theme of this entire day. But still, if we have a nurse who's trained in the NIH stroke scale, we could watch him or her do the assessment and get almost as much information as we would if we were with the patient ourselves. The fact is, in most facilities, there isn't a neurologist on site anyway. It's the ER doctors who are doing the stroke assessment, doing the physical, and then reporting that by telephone to the neurologist. With the mobile stroke unit, we can at least see with our own eyes what the exam is and even ask questions of the patient to really get a better sense of what needs to be done. Also, we're going to be able to review the CT scans and the CT angiograms in real time, not just with neurology, but also with neurosurgery and with neuroradiology, again, to rapidly diagnose the patient before they even leave their house and get them treatment started and transferred to the most appropriate facility. Okay. So that's the basic concept of why we're doing this and what we hope to gain by it.